Now, the global report heart failure registry showed that 43% of the overall patients who were de novo were from the North American and Southeast Asia. So Southeast Asia and North America given a lot of the trials. And 66% of patients in the prevalent study also were newly diagnosed HFrEF. So in a patient with a de novo HFrEF or a new onset heart failure, you can clearly see that sacubitril does wonders. There is a significant reduction compared to ACE inhibitor, even in the freshly diagnosed heart failure patients. There is a significantly lower incidence of composite of CV and heart failure hospitalization in patients who were put on sacubitril valsartan. Now, when you start sacubitril valsartan immediately after the patient gets admitted, and this was seen in the transition study, this clearly shows that the initiation of sacubitril valsartan in these patients had significant remodeling or reversing of the adverse remodeling and pump function month better than the patients with ACE or ARB in the de novo heart failure patients. Also, the troponin Ts, which is a marker of inflammation and ischemia, also came down with the sacubitril valsartan compared to the ACE inhibitor patients by a significant margin. Now, when you look at the heart failure with reduced ejection fraction, the primary endpoints, and the patients who had any kind of permanent disclosure, you could clearly see that the patients on the sacubitril valsartan arm, whether you had a de novo heart failure or you had a patient with a prior heart failure, both had significant benefit on the sacubitril group, and their heart failure admissions were much less. So what we learned from the transition study is that the first-line initiation of sacubitril valsartan in de novo heart failure patients, alongside the initiation of other guideline-directed therapies, is feasible, it's safe, and you get a better risk-benefit profile than in patients with a prior HF study, that is prior LV dysfunction and then coming with worsening. Early intervention with sacubitril valsartan should be considered to delay disease progression and should possibly be the first drug that you start in a de novo heart failure patients. Now, the update to the 2017 American College guideline, this was the 2021 guideline, clearly showed that in heart failure with reduced ejection fraction stage C, that means patients with LV dysfunction less than 40 who had clinical features of heart failure, the first important diagnostic algorithm involved the initiation of either ARNI, ACE, and ARB, and they went very strongly compared to 2017, where they said that ARNI could be given, and here they changed the tone and said ARNI is a preferred drug in this situation and should be the first choice of drug along with beta blocker and diuretics. So therefore, with this transition from 17 to 21, we have ARNI, which is no longer one of the choices, but here ARNI is the preferred choice in newly diagnosed heart failure patients. And then it goes on to talk about the various other scenarios of heart failure, the volume overload, the GFR problem, the potassium issue, patients who belong to the black race or do not respond to the ASR, the use of hydralazine, and also patients in sinus rhythm with a more than 70 heart rate needed IVBT. So it's very, very important to start well, to start with an ARNI, and then all the other drugs, foundation drugs, can be initiated. What is also important is the first 4 weeks should be used to get in all the 4 foundation therapies, that is the ARNI, the beta blocker, the SGLT2 inhibitor, and the MRA, along with the diuretics, of course. Small doses of all 4 foundation drugs should be initiated in the first 4 weeks to get the best benefit, because we have seen the data that the first 4 weeks are very treacherous and there's a very high mortality for these patients. And then over the next 6 months, we need to build upon their doses. The European Society on the other side of the Atlantic again gave a very strong recommendation for ARNI, and they say that it is a first-line therapy for heart failure with reduced ejection fraction rather than an ACE inhibitor. So you don't start ACE-ARB and then transition. You need to start straight away. So initiating drug is ARNI, and the European Society gave that very strong recommendation. And again, as I said again, we've talked about this, that the American College again stressed that ARNI is a first choice drug, very strong recommendation, and only look at an ASR when ARNI is not feasible for any reason.